It's my privilege to welcome you all for today's webinar 98 organized by NEMA OBGY Central on maternal death audit, learning from every life lost to save many more. I request respected Dr. Pradeep Musre sir to kindly introduce and welcome our guest speaker, Dr. Dilip Walke sir. So over to you.
Hello. Am I audible?
Yeah.
Hello.
Yes, sir, you are audible.
Yes. Maternal death is one of the most devastating events for the family and the treating doctor also and the healthcare team. Apart from the emotional impact, it carries the significant medico-legal implications. So every obstetrician hopes never to face such a situation. But every obstetrician must prepare to manage it professionally, ethically, and legally also. Today's session aims to help us understand how to prevent medico-legal complications through proper documentation, timely referral, effective communication, informed consents, and adherence to standard treatment protocol. We are fortunate to have with us Dr. Dilip Walke sir as an esteemed faculty for today's webinar. Sir is senior gynecologist and medical legal consultant who has guided many clinicians through complex medical legal situations. Sir is consultant at Jupiter Hospital, Baner, Pune and MediPoint Hospital, Aund, Pune. Sir was the past chairman, Ethics and Medical Legal Committee, FOXY, 2007 to 2010, and past president, Pune Obstetric Gynec Society, 2019 to 2020. He is a co-author of Uniform FOXY Consent book, and he is currently director of USPAIR ART Private Limited. I have had the privilege of knowing sir closely. Sir is exceptionally humble and approachable and helpful person. For me, he is not only teacher, but also a mentor and guide in my professional journey. Sir taught me, I remember that sir taught me the Misgav Ladakh technique of LACS since starting days of my practice.
Hello.
Thank you, sir, for accepting our invitation. And sir, it is an honor to have you with us, sir, today in this webinar. We warmly welcome you. And sir, stage is yours, sir. We'll start the webinar now.
Thank you. Thank you, Musre. I think there is some echo going on. Musre, तुझं दुसरं पण चालू आहे का? The second one?
Hello.
दोन ह्याच्यानी लॉग इन केलंयस ना? I think दुसरं सुद्धा चालू आहे. There is some echo. Now it seems it is okay. पण मध्ये मध्ये echo येतो.
Welcome, Dr. Dilip Walke sir.
Yeah. You had also logged in through Akshay, no? That you have to close down, otherwise there is an echo.
Okay. No, I am okay. That I have to close down, huh? Yes. Okay.
नाहीतर काय होतं, both echoes come.
Okay. Yes.
Sir, to begin with, we will just start with the basic question.
Yeah.
What is maternal death?
Yeah.
Which maternal death come under this topic, maternal death as such, and why every
Yeah.
maternal
So
death deserves a
anything that
systematic
is,
review.
yeah, yeah. So basically, any death that occurs in the obstetric career of the woman, I mean, that can rise from when she was an early pregnant woman or right up to delivery and later on also. All that comes into maternal death. The reason being, maternal and child health is a public health issue, and every death has to be explained in the parliament also. So what happens is, any if there is any maternal death, then not only it is that you are questioned, but even the government is questioned in the parliament for the kind of care that they have given. So that's the very simple definition of maternal death. So anything that the obstetricians do and there is a death, that comes under maternal death.
So every maternal death, it requires a audit. So what is death audit? Is it same
See,
or different from reviewing a case sheet?
basically, as something, an audit that is done by the appropriate authorities of the place that you are practicing. So, uh, as private practitioners, we say face an audit after a death by the appropriate authorities of the area that you are practicing. Like if you are practicing in Pune, then it will be the Pune Municipal Corporation. If you are practicing in Bombay, then that will be a Bombay Municipal Corporation. If you are practicing in some village, then it will be the district authority there. Now, the audit is not about your negligence. So, this is one thing that everybody needs to understand, that whether a doctor was negligent or not in a particular treatment which caused a maternal death, that is not what the audit is trying to find out. That is done by the courts. So if it is a criminal court, it will be done by the criminal court. If it is a civil matter, it will be done in the civil court or the consumer court. What they are trying to do in the audit is, what is the population, what is the which kind of patient died, was she accessible to treatment or not, her house was how far from the place where she actually came for delivery or for any kind of a care. So that is what they are trying to find out. So what I always tell is, don't be afraid to face the maternal audit. You will have given a proper treatment. What the audit people are trying to do, they are not supposed to ask you questions like ye kya kela and ye ka nahi kela. All that they have to do, I mean, in terms of trying to find out whether you're negligent or not, that is not their job. So audit is this kind of an audit because the questions are raised in the parliament, and that's the reason why they do the audit, and this report goes to the minister and he answers the question there. You got it, Namita? Is there anything else you wanted to know on this?
No, so just I wanted to know more, like if a case maternal death occurs, so that
Yeah.
means for the audit basis and for our safety, should we immediately inform the police about the death?
Yeah. So, first of all, you have to understand that there is no law in our country which tells that every death has to be informed to the police. Like, so for example, if there is a cardiac case that is being operated and it's a grade 4, ASA grade 4 patient, we are not expected to inform every death on table to the police. A cardiac surgeon is not going to inform this death to the police. But when it comes to a maternal death, what happens is that maternal patients are usually young patients and they are not expected to die on table. And so there is a possibility that there can be a suspicion on the part of the relatives about the treatment given by the doctor. And that's why it is prudent practice to inform the police at least. So the police can come in. Police will come and decide whether a medico-legal PM is required or not required to be done, depending upon whether there is any suspicion that is there in the minds of the people. And then the police will take the body away for medico-legal PM. Does that mean that there is a statutory rule which says that every maternal death has to be informed to the police? Basically, there is no such rule. But then it is always a prudent practice that you inform the police, because in case that the relatives have got any problem, let the police and the relatives decide whether the body has to be taken away for a medico-legal PM or not. Which comes to the second part of your question, whether in any maternal death, can you give a death certificate or not? Maybe, Namita, this is what you may be wanting to ask me. Now, supposing if I am operating on a patient, I'm doing a cesarean on a patient who's got placenta previa, and the patient died because of lot of bleeding. Now, don't you think that I know the cause of death, that she died because of multi-organ failure, because of sudden drop in the blood
Suddenly.
pressure,
Mm.
because of postpartum hemorrhage, because of placenta previa? Don't I know the cause of death? Yes, I do know the cause of death. So basically, there is no law in our country which prevents me from giving a death certificate even to a maternal death patient. Your job is to call the police, let the police decide whether there is any suspicion or not, and the onus of sending the body for a medico-legal PM is with the police and not with you. Basically, what we try to do is we try to take that onus on ourselves. आणि रिलेटिव को एक्सप्लेन करने का काम हम खुद करते हैं कि नहीं नहीं, ये पेशेंट को हमें हम लोग डेथ सर्टिफिकेट दे नहीं सकते, वी हैव टू टेक दिस बॉडी फॉर पीएम एंड अदर थिंग. That is not your job. That is the job of the police. You can tell the police if you know the cause of death. You can tell the police that I know the cause of death. And if you feel there is nothing suspicious, I can give the cause of death. I have done this in many cases. And Musre will be here with me. He knows some of the cases that we have given a cause of death in Pune, and matters could be properly solved even if it was a maternal death.
So,
Yes, sir. Yes, I remember that also. But what is next question is, what is your opinion on very common narratives that the चिंता मत करो सब कुछ ठीक हो जाएगा? It's a
Yeah,
very
this
usual phrase we talk with patients, and
exactly.
that narrative it makes the problem afterwards.
Yeah, that's what happens. I mean, whenever such a patient comes to us in an antenatal visit and they ask you, "Okay, सब कुछ ठीक है ना?" The kind of answer which we usually give is, "Sagar ठीक है, don't worry." That kind of a thing. And because of which people tend to have this feeling that nothing can go wrong in a delivery. But what I do in my practice, and Musri, you must have seen it in MediPoint Hospital,
Yes,
that
yes.
I have in the antenatal classes, I have a 15-minute, I give about 9 to 10 talks to the patient when I do an antenatal talk there. And while doing the antenatal talk, there is one presentation on what I call as the unforeseen. And in the unforeseen, I talk about amniotic fluid embolism. In the unforeseen, I talk about PPH. In the unforeseen, I talk about shoulder dystocia and other such things that can come as a surprise. And that is where I tend to tell the patients that there is a possibility that something can go wrong in the pregnancy. That is point number one. Point number two, I have started taking consents for even a vaginal delivery. And that consent for vaginal delivery I take during the antenatal period itself. And during the antenatal period, I talk about everything that can go wrong in the during the delivery, like a PPA, like an amniotic fluid embolism. So the patient is aware that these kind of complications are possible in a normal delivery. And when in this normal delivery, we have to do say an MRP, or we have to do say a cesarean section or an episiotomy, that other thing, or an instrumental delivery, you take an additional consent there also. But whenever the patient comes in labor, start getting to this habit of taking a consent for a vaginal delivery. And there is no such thing as a normal delivery, that you stop using that term at all. I mean, there is nothing normal about any delivery. Even a vagina, it has to be a vaginal delivery or an abdominal delivery. दोनच डिलिव्हरी होऊ शकतात. I think there is a lot of disturbance. I don't know from where the noise is coming.
Naminda, can you mute yourself, please?
हाँ
Yes.
नमिता म्यूट कर दो सबको.
हाँ अभी अभी वो
How
गया थोड़ा
important
सा.
is the informed consent in obstetric practice, and
Yeah.
in which situation should special consent to be obtained? It's already you are informed, you are told this fact,
Correct.
but is it necessary to take the episiotomy consent, ventus for application consent, or forceps application consent?
Yeah.
It's
So now,
is it necessary?
yeah, it is. See, what happens is, supposing you put
Huh.
in a forceps. Now, there are lot many court cases against forceps delivery. Now, supposing if you put a forceps and you have not taken any kind of a consent. Now, consent is not just about taking signature. Huh? So, म्हणजे patient is in labor, patient is howling in pain. The relatives are there, they are worried about whatever is going to patient deliver कधी होणार आहे. त्यावेळेला you just call the relatives inside, you take the patient's signature when she's just lying down, howling in pain. Anybody in the court of law can prove that this consent was not a valid consent because the patient was not in a position to understand what was happening. So to make this consent of a instrumental delivery a valid consent, you should have, I mean, there has to be an evidence that you had talked about forceps delivery, you had talked about ventouse delivery with the patient. And where can you give this evidence? Number one, what I used to do was I used to take these classes, antenatal classes, and I used to give them PowerPoint presentations. So I had an evidence of the PowerPoint presentation with me, which I could give in the court of law as an evidence that I had told them about forceps delivery. Secondly, now what I have started doing, and through Foxy, we have devised those consent of a vaginal delivery. Now, when I take a consent of a vaginal delivery, it is not merely a signature. What that consent, if you go on the Foxy website and you see the consents are divided into two parts. One is the routine undertaking that we usually take. की मी अमुक अमुक लिहून देते की मला सगळं एक्सप्लेन केलेलं आहे and I know what the complications are वगैरे वगैरे वगैरे. But nothing has been mentioned as what complications did you explain. So what every consent, we have done it for about 30 OBGYN cases. Every consent has got two parts. One is the undertaking part, which we usually take. And second is the information part. So I have got about 4 or 5 A4 size papers on only information on vaginal delivery. Now, information on vaginal delivery is going to talk about forceps. It is going to talk about episiotomy. It is going to talk about ventouse. It is going to talk about amniotic fluid embolism. It is going to talk about a pulmonary embolism, PPH, everything. On the top of it, again, during labor, if she undergoes a cesarean or if she is undergoing a forceps delivery, now when you're taking the consent, you're merely taking the signature, but you have a proof that you had made her informed about forceps and ventouse when she was in the antenatal period in a proper state of mind to understand what is forceps and ventouse. So consent is not just about taking signature, consent is about all this. Yeah, Namita.
So yes, as per the consent part, so many times what happens during section, like I will like to discuss a case in this scenario. A 30-year female, previous LSCS. She had a history of localized placenta adherent in her previous pregnancy, and she was counseled for not taking up with the second pregnancy by her gynec. But
Correct.
still, patient came unregistered at term to a setup, and she did not reveal her history. And during LSCS, it was found that placenta was densely adherent.
Okay.
But the USG was showing a normal placental position.
Okay.
And patient profusely was bleeding, and blood was arranged. By the time the patient's relative were counseled for OH.
Okay.
But relatives took immense time to decide, and they were not ready to give consent for OH.
Okay.
So in such case, can a husband or relative refuse for such a life-saving procedure?
No, correct. So here there are two things that you are wanting to discuss. One is the contributory negligence on the part of the patient and the relative for having not given you the information that was important for you to know. So that is point number one. So if this case goes in the court, we sometimes tend to feel that courts are unreasonable astat. Courts are not that unreasonable. If you present your case properly, wherein number one, you tell them that there was a history of an adherent placenta in the previous pregnancy, which was very important for us to know. And she was advised not to undergo a pregnancy. So this pregnancy was indeed a very high risk pregnancy. Despite that, she came to us as an unregistered patient. So the judge would know that the doctor was managing a case where unexpected things were going to happen in front of him. That was point number one. Point number two, if you can prove in the court of law that a particular step was life saving, then there is no need to take anybody's consent. You can go ahead and do it. Like if you're doing a cesarean and if there is a lot of bleeding, Now try to understand, does the court say that the patient is bleeding, the BP is 80, and you take the consent of the patient before doing an OH? Court is not so unreasonable to expect you to do that. And court is not so unreasonable to expect you to go out when the patient is bleeding, talk to the relatives, and then come back and do the OH. So you can, as a surgeon, go ahead and start doing OH while somebody in the OT can go out and just inform. This is information. This is not consent actually. If it is can be proved in the court of law that indeed it was a life-saving step, then there is no need to take a consent at all.
Yes. Death on the table or in labor room ward, this is always considered as a negligence many times. But many times the first questions usually have been asked by the police that the BMS/MS can do the delivery.
Yeah,
What is
see,
your
now
opinion?
the only fact that you have been given a degree of MS. So if you are practicing in Maharashtra, then you have this I mean, the Maharashtra government has given you a permission to write those allopathic modern drugs to the extent that you are trained. So number one, you can definitely give all those methogens and prostaglandins and whatever injections that you have in your armamentarium to save the life of the patient. Number one. Number two, the fact that you have done your MS and during your MS, you're taught how to do a normal delivery, you're taught how to do a cesarean, then all that can prove in the court of law. But I always say there is a slippery slope when it comes to Ayurvedic doctors being given the permission to write allopathic drug, because you have been given permission, but not by the council that governs the modern medicine. It has been given by the council that governs the Ayurvedic medicine, and your names have not yet been there in the state register that is maintained by the Maharashtra Medical Council. So your next advocacy from your side, from NEMA, would be to see to it that your names are included in the state registered maintained by the I think there is a state register that is maintained by the Maharashtra Medical Council. So if this is done, then there'll be no problem. But at this moment of time, yes, you can defend yourself even if you're doing conducting a delivery. No issues. Does that answer the question, Dr. Pradeep? Hello? Am I audible?
Sorry, sir. I think there is some problem with Mr.
Hello.
The
Hello.
network.
Acha,
Hello.
are you okay with
Yes,
the answer
yes.
that again? Yeah.
Yeah. Definitely, I will do the through Nima OBGY Society. Will that try to do that? Definitely.
The
And
only slippery slope that NEMA should do advocacy about is try to see to it that your names are included in the Maharashtra Medical Council state list, because that is the only slippery slope that you are walking on at this moment of time.
Okay. Many times in maternal collapse in labor or in OT, the problem is the resuscitation. Who should do the resuscitation in emergency situation? What is your opinion?
The first thing is, one is the anesthetist. Supposing if you are in the labor room and the anesthetist, I mean, if you are in the OT and the anesthetist has already come there for giving anesthesia, naturally, these are the ones who are absolutely well trained in
But
putting in a
in labor room,
bed.
many times the anesthetic is not available.
Correct. So what is one thing that is most important, which is neglected by everyone all across the country, is your training for an advanced life care support. I mean, there are simulation trainers available wherein you can call them, they will come down and teach you how to do an endotracheal intubation and resuscitation. These kinds of certificates that you have, supposing if you have a certificate, your resident doctors have a certificate, not of basic life support. Basic life support certificate is taken by anybody and everybody. But advanced life care support is one kind of a certificate wherein you are also trained to put in a endoscope, endotracheal tube. So these certificates that you may have will help you in the court of law is a different matter, but it will help you in resuscitating that patient also. Number one. Number two, if you're not comfortable putting in an endotracheal tube, the most easiest thing that you can put to ensure that the respiratory system is there in our hand is just an laryngeal mask. Putting in a laryngeal mask is as easy as putting in an catheter to a female patient. A urinary catheter डालना जितना आसान है ना उतना ही आसान laryngeal mask है. So call someone who can train you in advanced life care, and not only train you, but you should have a certificate of an advanced life care support, so that whenever there is a problem, not only you can actually save the patient, but you can prove in the court of law that you were trained to save the patient that way.
Okay. One course is also run by the Dr. D.Y. Patil Medical College. That is Advanced Life Support in Obstetric, ALSO. That is also very fine and very informative course. That is. It contains all these maternal collapse and obstetric labors and PPH, how to manage it, and all these things.
Not only that, Dr. Pradeep, if you are, because you are in Pune, I know of a group of anesthetists, one of which is my own wife. You can call them. Not only they will give you a simulation training. I mean, they completely create a scenario that there is a patient which has come in labor and now the patient is having PPH. If I ask you how to manage PPH, you will tell me, अरे पिटोसिन लेने का, then methogen देने का, नहीं तो prostadine देने का, then massage करने का, everything you will be able to tell. But when that thing actually happens, that time is the time that you tend to forget many things. This kind of a simulation training, again and again going through that simulation scenario, helps you not only just about the clinical management. Clinical management is only, I will say, only 25% of how you manage a maternal situation. 75% is about who will be the leader at that time, who will make the phone call to call others there, who will arrange the blood. All these things, teamwork is what is taught during these scenarios. And I think if you have, again, some certificates to tell that you have indeed been trained in such kind of scenarios, that will have a lot of effect in the court of law. When the court of law, the judge comes to know that these people have not only managing deliveries, but they have trained themselves in managing such situations, that is the time the court will have a very positive approach towards you.
Okay.
So regular emergency drills and team training improve maternal outcome and reduce medical legal risk?
100%. Not only, see, sometimes whenever we are discussing medical legal issues, now we tend to say, do this, do that, document so that you will save yourself in the court of law. That is a different end result altogether. I am telling you, do this, do simulation training again and again. Just because you have passed your MD or MS, and just because you have had papers on PPH, does not mean you will be able to handle a PPH better. To handle a PPH better is you have to go through that situation again and again. Don't you think when we started doing a medical termination of pregnancy and there was a retained product of conception, in the early days of practice, we used to be so tensed. अरे मेरे थे एक रिटेन प्रोडक्ट रह गया, रात को नींद भी नहीं आती थी. Nowadays we are so confident after so many years of practice. Whenever there was a previous LSS, you wanted to do a section, you used to be so worried. कैसे करेंगे, प्रॉब्लम हुआ तो, एडिजेंस हो गया तो. As you go along, you become confident and then you can manage it better. Similarly, maternal death, you're going to actually face a situation of a maternal death like situation only maybe once or twice in your life. Only once or twice in your life. I mean, we are not doing so many bad things that there is going to be maternal death happening every month in your life. But if you're trained for it 8 to 10 times before, of in a simulation scenario, then your performance there will be much better, and there are the possibility of you saving the patient also is much better. So do it for saving the patient. Don't do it for medical legal safety. That is another advantage you will get.
Okay. what are the other equipments like anesthesia machine and all drugs should be in emergency tray
Yeah,
like crash cart and all these things?
yeah.
Is
I
it
know, Musre,
necessary to anesthesia machine?
Yeah, I knew you were going to ask this question because we had discussed it in one of the cases. See, like there was a time when we used to give lectures all over the country, and we used to say that minimum every nursing home should have a boils app. I'm talking about 35 years back. I mean, about 35 years back when I used to go around the country, I used to talk about minimum you should have a boils apparatus because that was the time when people, small nursing home did not even have a boils apparatus. But now boils apparatus is there in every nursing home. So if I were to ask all those who are attending, everybody has a boils apparatus in their nursing home. Now we go one step further, and now people say not only boils apparatus, but you need to have a defibrillator. But it is wrong to say that you need to have a defibrillator. I say you need to have a defibrillator which is regularly charged. If you have a defibrillator which is not charged, it is
Yes.
not going to be useful. So, number one, say that you need to have a boils. Say that you need to have a defibrillator which is regularly charged. Very important. And now you will not be spared if you are doing major cases, if you do not have an anesthesia workstation, and if you do not have a monitor without an ETCO2. Because if you have an ETCO2, you will be able, the anesthetist will be able to diagnose hypoxia much earlier than later on. Your pulse ox is not going to show that. The hypoxia will be, first of all, detected early. Proper steps will be taken, and supposing if there is an anesthesia workstation, then and the patient is put on a ventilator, then the hands of the anesthetist are free to give the other drugs that are needed to be done at the time of emergency. That is number one. Medico-legally, you will be able to save yourself better because then in the court of law, you will be able to say, not only my nursing home had all the equipment, my nursing home also had a ventilator, because this is the language that the courts usually use. तुमच्याकडे ventilator होता का? Yes, I had a ventilator because an anesthesia machine, an anesthesia workstation essentially has a ventilator. So if there is a ventilator, the patient can be put on a ventilator once the airway is secured, and all the drugs can be given by the anesthetist. So now, if in the infrastructure you only have a boils and you only have a monitor which is showing just your pulse, BP, NIBP, and saturation, that you will not be able to save yourself in the court of law. Eventually, maybe the court is going to become mature slowly and gradually. You need to have a monitor where there is a temperature probe, where there is an ETCO2. You will have to have an anesthesia workstation with a ventilator to help the patient who has crashed. In the crash cart, like just as big nursing homes have a crash cart, the moment there is a problem, they they call a code blue, and once the code blue comes, a sister comes with the crash cart there, and the crash cart has got everything, all the drugs, the equipments, the on the trolley. Now, in a small nursing home, you may not be able to afford a crash cart, but at least you have a tray in which all the drugs are there, tray which even the scissors are there, sticking plaster is there, intracath is there, everything. So if you just call one sister, get me the emergency tray, that tray should be enough for you to manage a cardiac arrest, for you to manage an anaphylaxis, and for you to manage PPH and everything. So you create your own tray, you have your own method of calling just one sister, get me that. You should not be telling the sister katri घेऊन ये, sticking plaster घेऊन ये, intracath घेऊन ये. That is not the way to manage an emergency. To managing an emergency, get the emergency tray, and the emergency tray should have everything on that tray.
So
Yeah,
documentation is often described
yeah,
as a doctor's strongest legal defense.
correct.
So, what common mistakes generally medicos do that leads to medical legal problems while
Yeah, I'll tell you.
documentation?
See, documentation is a big discussion, Namita, and it can go on and on forever. But I'll give you some tips when it comes to documentation when there is a maternal death kind of a situation. See, what I say is have this protocol of management of cardiac arrest and anaphylaxis and PPH and eclampsia, all this thing printed laminated and pasted on the wall of your OT or your labor room. So what happens is whenever there is a PPH or whenever there is a cardiac arrest, all you can do is copy down whatever has been written there. Then what will happen? Your documentation will not, there will be nothing in your document that you have missed out. Otherwise, if you were to remember and write, then there is a possibility that you will make mistakes while writing that and you may be missing out on something. That's the reason why I say have everything ready, printed, pasted on the wall. So while making notes, just copy down from whatever has been written there, and that helps you in the management also. So because sometimes you tend to forget certain things, which you will never forget if all these things are printed and kept inside the OT. If you come and see the Medipoint labor room, you will find that Medipoint के labor room में इतनी सारी चीजें चिटका के रखी है कि you feel अरे wall कहाँ पे है, but that's okay, that doesn't matter. My resident doctors can just copy down the notes from there in case there is a problem.
So is it acceptable to often like alter or add to medical records after an adverse event has occurred?
See, if see, courts usually do not like any medical record to be altered. Supposing there is a genuine reason for you to alter whatever has been written there, don't strike it out in such a way that you will totally hide what was written before. Like supposing at 10 o'clock you had given not injection pitocin but injection methergine, and you want to strike out pitocin and write methergine, supposing. To strike the pitocin in such a way that the pitocin can still be seen. And then near that you write methergine, and then at what time you had written the methergine and what time you had given. So in the court of law, what you're trying to say is, मैं कुछ भी hide नहीं कर रही हूँ, मैं जो है वही बता रही हूँ. Because the moment you show that you are trying to hide something, then the court starts become suspicious, and the moment the judge starts become suspicious, तुम्हारा केस उल्टा जाना शुरू हो जाता है. Because in one of the conferences, uh, one of the judges, I mean, I have arranged many conferences and I've called very big lawyers for my conferences. To name a few, I had even called Advocate Jetmalani at one point of time. So in one of the conferences, Advocate Jetmalani told me, जैसे आप लोग बोलते हैं ना, पेशेंट को देख के हमको पता चलता है पेशेंट लेबर में है कि नहीं, या देख के मुझे पता चलता है कि पेशेंट को एपेंडिसाइटिस है कि नहीं, वैसे आपके नोट्स देख के हमको पता चलता है कि ये नोट्स मैनिपुलेटेड है कि नहीं. सो डोंट बी अंडर द इंप्रेशन के यू कैन फूल द जज. But if you are striking it, I mean, nobody says that there cannot be a situation where you are managing an emergency. There may be some mistakes that you may have done on the day prior in the notes. Strike it and write it, but strike when it has been struck off, or what time it was struck off, what new thing was added, and the time of the new thing whenever it was added.
So electronic medical records, they are legally valid or not?
Yeah. Electronic medical records, number one, are legally valid. And a day is going to come, Namita, when the government is going to tell us that now no more written notes, everything has to be electronic medical records.
Paperless India.
Yeah. So that this is going to come because government, see, the only way the government will be able to get the data, and you don't even realize what data is all about, because in this era of artificial intelligence, data is the thing that is making that is causing the machine learning for the artificial intelligence. So data is one of the most important. The data is going to be even costlier than gold, let me tell you that. And the government is going to put pressure on us that everything has to be a electronic record. Like for example, an ART Act. Now it is not just an act. They are saying that everything that you do has to be reported to the National Registry. So everything will be on the website. So every patient who's undergoing an ART treatment, every case, every IUI will be now reported as to what stimulation was given and whether the patient became pregnant or not pregnant. So the data is going to be a robust thing that India is going to provide the whole world. And the AMR is the only way to do that.
Many times the drugs injections are kept by sisters and all this, but they don't see the expiry dates of these injections.
Yeah.
And many situation that in emergency case situation, the houseman and sisters write down the prescription of injection adrenaline, injection dexa, injection ifcorline, and the prescription of life-saving drugs in emergency. Is it looks good?
Never. Never, never. The moment you give a prescription of a life-saving drug to the patient during emergency only proves that your hospital was not adequately stocking these life-saving drugs. So if Busre, you have a situation in your hospital and you need a life-saving drug, you give me a call. I
Yeah.
stay only about 5 kilometers away from your nursing home. मला फोन करून सांग डॉक्टर वाळके सर माझ्यासाठी आहे ना ॲड्रिनलिनच्या अँप्यूल लवकर घेऊन या. I will come and give it to you, but don't give the prescription to the patient. I can tell you one case, and Musre would know that place. It is a place called Pashan, wherein one of the doctors gave a prescription of a cell for the pulse oximeter that is put on the hand. Chote cells astat, the small pulse oximeter. Now, this patient is a cesarean case where there was cardiac arrest. The patient is vegetative. Patient just died 4 months back. Patient was vegetative for 8 years, wherein this doctor had given a prescription of a cell of pulse oximeter, which proves in the court of law that the doctor did not even have a pulse oximeter. How will she monitor hypoxia? So please, no life-saving drugs prescription to the relatives. That those drugs have to be there in your hospital. If at all you need, and if it is not there, call your friends. That is what our friends are meant for, isn't it? So you can give me a call. I'll come down and give all the drugs to you.
That is important. The
Yeah,
call
Namita.
for help, definitely.
Call for
Sir,
help is the most important.
generally when any adverse situation is happening in the OT, the staff and the maushis and they all are come to know prior to the relatives. So how we communicate this adverse condition to our staff first and then to the relatives so that no misconception occurs? What should we do?
I always correct. I always say that before even you talk to the relatives, you have to talk to your staff, your aya, your metrani, the support staff, then your receptionist, your यानी कि वो security. Call everybody inside and tell them what happened so that they talk in the same voice. Because I'll tell you, whenever there is a problem, we are in the OT. Our staff is in the OT. आउटसाइड जो लिंगरिंग आया मेत्रानी रहते हैं ना, तो यूजुअली द रिलेटिव्स विल आस्क अरे अंदर क्या हो गया, एंड इफ द स्टाफ सेज कि अंदर बहुत ब्लीडिंग हो रहा है, देन will you be able to defend a case of amniotic fluid embolism if you want to say that the patient did not die because of PPH but died because, supposing, I'm just giving you an example, supposing if you want to defend a particular case as a case of amniotic fluid embolism, and if your aya metrani goes out and say अरे bucket भरून bleeding झालंय, then your case is lost. So that's the reason why call them. You decide what is going to be your defense. Call everybody inside. Tell them what happened, why it happened, and you need not tell them that this is going to be our defense and don't tell this and don't tell that. But then you tell them in the language that they will understand, so that when they go out, they will talk in the same voice. There cannot be different stories given by different people in our hospital.
Yes. Now the important topic is the transfer of the patient to the tertiary unit. How to shift the patient at tertiary care hospital after death or before death? First, we'll take the before death.
Now, supposing you decided to transfer this patient to a tertiary care hospital, first of all, see, you cannot transfer an hemodynamically unstable patient. You have to make the patient transferable. Transferable means you have to make the patient hemodynamically stable enough to go in the ambulance and go reach out to the tertiary care hospital. Number one. Number two, you have to accompany the patient either yourself or somebody who's accompanying the patient should be trained and with a certificate of advanced life care support. So if he or she has got a certificate, then suppose during the transit there was cardiac arrest, she will be able to prove in the court of law that I gave all the resuscitation, me chest massage dila, me he drug dila, te drug dila. That can be defended in the court of law. So number one, as far as possible, you go. Number one, Number two, it has to be a hemodynamically stable patient. Number three, if you have got time, then take consent for transfer, because you have to ask कहाँ जाना है. And if the patient says नहीं sir आप जहाँ भेजो वहाँ जाने को तैयार हूँ, then at least send it to a hospital where you have connects with the ICU doctor. So if you have a connect with the ICU doctor, then they will not pass a comment which can go against you. And that's the reason why I always say you should have proper friends in every tertiary hospital that are there. Go to them, meet them, call them for a talk somewhere in your NEMA conferences. But you need to have a good relationship, because one remark given by the junior most person in the ICU can go against you. That is one. And once you transfer the patient there, go and visit the patient regularly. Even if the patient is dying, visit regularly, because all this is noted by the relative. Doctor Sakar Sandhyakar yet hote. And show that concern that is there in your mind if the patient is indeed going to die. And after the death, of course, you have to pray that there is no case against you. That is always possible.
So many a times, like when such critical situation happens, there are many local goons, or we call them as some connected with politicians. They try to interfere and hinder the treatment which we do. In such cases, sir, what to do?
Yeah. First of all, no, I have been saying death on table and possibility of mob violence, and every time I have been ridiculed for saying this, that you call the politicians yourself. You call the politicians yourself even before the relatives call. Because every time I make this statement, the people say, अरे politician म्हणजे दूधारी चलवार है, double edged weapon है, आज वो आएंगे आपको help करेंगे, कल आपसे और भी help मांगेंगे. But what I say is, it is today when your life is in danger, the life of your staff is in danger, your hospital is likely to be ransacked. At this juncture, this is the time for whatever money that we have given them for the Ganpati festival, for the party fund, whatever free treatment we have done for their wives. This is the time to take the repayment back. I am not saying involve the politician for small little medico legal case. No. छोटा सा मेडिको लीगल केस होगा तो किसी को फोन करके मत बुलाओ, नॉट नीडेड. But now today, when there is a maternal death in your hospital and there is a possibility of a mob violence, you call the politician before they call the politician. The moment the politician comes as your person, he will be under pressure to help you, number one. And number two, your hospital should have a lot of CCTV cameras. The moment there are CCTV cameras, the politicians will take it a little lightly, unless the politician is somebody like that Mhatre of Kalyan Dombivli. That Mhatre, either he did not know that there is a CCTV there, or maybe he's such a crook that he did not bother about it. So most of the politicians, at least in Pune, the moment they see that there is a CCTV camera, they will behave properly. So CCTV cameras, call the politician yourself, because the moment there is a death in your area, they are going to any which ways come. Any which ways. त्यांना कळलं की ते येणार आहेत. So why not call them beforehand?
Okay. One of the patient is the maternal collapse, and patient active resuscitation done, but patient not revived. Can we do the perimortem section in your hospital? Is it legally? Is it legally allowed?
It can be done. There is no requirement of an operation theater also. If there is a perimortem, this is what we teach in the simulation also. And if there is a simulation scenario that we conduct, if you call, I can do it in your hospital also, Pradeep. In the scenario that we conduct for a cardiac arrest, and if the patient is dead, then within 3 months time, minutes time, you'll have to remove the baby, right? Now you cannot shift this body. Now this is a body. The patient is dead. You cannot shift this body from where the death has occurred in the labor room to the operation theater, and then you cannot actually have the autoclaved instruments there, and you only will use what is the point in using an autoclaved instrument instrument on a dead patient? There is no need to do that. So you take a knife and immediately do the periportum cesarean, no problem. I mean, I say this, but I have not done a single peripartum cesarean section myself. But I know of many cases where this has been done and it has not caused any problem in the court of law.
Okay. Death occur
In
in
fact, the
hospital.
judges were very happy that you saved the life of the child. Judges were happy about that.
Okay. If the death occur in your hospital and we have to ship the patient in tertiary unit for the to showing the to relatives and all these things, and for DC, can we give the DC directly in from your side in
Of
your
course, you have to
hospital?
do it. See, all this
Or
jugards, no, which some of the medico-legal experts used to tell you about 10, 15 years back, all these jugards will not work now. Like uh, death occurred in your hospital, create a show that the patient is still alive and we are trying to do something, shift this patient to an ICU somewhere and let that patient be in that ICU for 1 or 2 hours, or baad mein declare karo. All this so that mob violence nahi hoga. All these things doesn't work nowadays, because nowadays there are monitors where it will be seen when was the straight line there. So because if there is negligence proved in the court of law, at the most what will happen, you will have to pay compensation, and that the compensation will be paid by whom? By the professional indemnity company. But the moment you have been proved to do a forgery, then the punishment is arrest. So would you want to be arrested, or you want to give compensation which actually you're not going to give? So I would say that if the patient died in your hospital, in your OT, say that the patient died in your OT, that will save you.
okay.
Sir, Bharatiya Nyaya Samhita, after the
Uh,
evolution of this, how doctors are benefited?
See, I will tell you, Namita, again, a lot of advocacy will have to be done from the Ayurvedic people. Bharatiya Nyaya Samhita has finally codified medical negligence. Purvi काय व्हायचं? 302 and 304A. Yeah, there used to be a confusion between the two, and the police used to arrest the doctor because there are three things. Whenever there is a problem, there is a conduct, there is an intent, and there is a knowledge. Right? Conduct ahe, you have done the surgery and the patient died. Conduct ahe. Was there any intention to cause death? No, there was no intention to cause death.
No.
Third thing, knowledge. Now, the police used to say, Tumi the doctor are. You have got all the knowledge. So there is conduct also, there is intent also, and there is knowledge also. I mean, there is no intent, but there is knowledge.
Independent
So
knowledge.
we'll arrest you under 302. I mean, part one. And त्याच्यानंतर मग then they used to arrest, and it was non-bailable, and we had to take the bail from the magistrate. Now, after Bharatiya Nyaya Samhita, now every case of medical negligence, they will have to now put an FIR under 106(1). But unfortunately, while actually defining who is an RMP, they have defined RMP as the one who is registered under the IMA Act, whatever that act is for the modern medicine, which means that they have excluded the Ayurvedic and the Ayush doctors from that, unfortunately. Or you people will have to do a lot of advocacy to include your name in that. Because
So
at this
it's the
moment,
irony of the system. It's the irony of the system. It's Bharatiya Nyaya Samhita, but it is not including the Bharatiya Chikitsa Paddhati.
exactly. So there, I mean, I think this is a slip of their, yeah. I don't think they had any intention of excluding you people. I'm very sure about it. They did not have that in their mind. All you have to do is some advocacy to put that in the definition of the registered medical practitioner. You have to also include the Ayush doctors. If that is included, otherwise you people will going to be again in the trouble, because there you will be again tried under 304, not under 304A, but 302. So then again, there will be a problem.
So, as per time constraints, sir, we want to learn more from you from such valuable insights. But due to time constraint, we have to conclude the session. So, as we
Yeah.
conclude, so today's discussion reinforces that good clinical care alone is not enough. Good
Yeah.
documentation proves the care. Informed consent respects patients' autonomy. and timely referral ensures continuity of care. Together, these three principles, it strengthens patient safety, improves maternal outcomes, and also provides medical legal protection to our healthcare professionals. On behalf of NEMA OBGY Society Central and all participants today, I sincerely thank our respected speaker. Sir, you have enlightened us with your knowledge and experiences, and we are thankful for your such practical and valuable insights. Also, will be obliged if you also give us further some such interactive sessions in future.
Always.
So today's take-home message which we have got, it is good documentation tells the story, informed consent builds the trust, and timely referral saves lives. And lastly, maternal death audit. It transforms every tragedy into an opportunity to improve care. Thank you so much, sir. Thank you.
Thank you so much.
Thanks a lot, sir. It was a wonderful session.
Yes.
Truly.
Yes. Any questions from
thank
audience?
You all of you.
Any questions?
I think they have in the chat box. So, Namita, please take the questions if they are having some.
There are some questions in the chat box. Can you ask Namita? The chat box माझा open होत नाही.
Sir, in the chat box, they have just thanked for this wonderful session.
Okay.
And they are just asking for your number, mobile number.
Please give. Write
yes,
down.
surely, sir.
Yeah. We will definitely.
98220 38583.
220 38
583.
Sir, I want to ask one question.
Yeah, please.
Yes. If the LSS is done and severe PPH, we manage the patient, but the patient died. But patient relative is not willing to do the refuse for MLCPM. Can we give the death certificate? And what about the this? They are refused, totally refused. We don't want PM. We are going to write down the all these things for hospital also and doctor also, but we don't want PM. What should be done?
That's exactly the answer that I gave when Namita asked me. Number one, there is no, you have to understand these rights of ours. While I give you the right, then actually what you have to do on the spot, it is a little different. Number one, there is no law in our country which prevents you from giving a death certificate if you know the cause of death. That's point number one. So do you have a legal right to give the death certificate in a case of cesarean where the patient died because of PPH? Yes, you have a right to give. Number two, is there any statutory law in a country that every death on table has to be informed to the police? Answer is no. But because you are doing a maternity case where the patient is young, where the patient is not expected to die on table, and there is a possibility that the relatives will have a suspicion on you, that's why it is your duty to call the police. Why call the police? Police is the person who will take the onus of deciding whether the relatives have got any suspicion on you. And if the police feels that relatives have some suspicion, will take the body away for a medico-legal PM. That is number one reason why the police will take the body for medico-legal PM. The second reason is if you tell the police ka mala mahit nahi baba cause of death, you take the body away. Then the police will take the body away for medico-legal PM. But if you know the cause of death, and if you feel I can defend this cause of death in the court of law, and even if this case goes in the court, then you have full right to give a death certificate. Number two, all these years we used to say that patientच्या relative कडनं आपण लिहून घेतो ना, I have got nothing against the doctor, I have got nothing against the hospital, and there is no negligence वगैरे जे लिहून घेतो, it is useless and there is no need to take all that, and even if you take, there can be a case. This may not be useful to you, but it may be useful to the police in the court of law. The police will present this in the court of law and say that the relatives were saying that there was no suspicion, and that's the reason why I did not take the body for medico-legal PM. Medicoligal PM because the doctor was telling me that doctor knows the cause of death, and the relatives were telling me take the body for Medicoligal PM, and the body was cremated.
So
Okay.
one more question.
Yeah.
Uh, Sir, if in a labor room or an OPD, if we display the complications through various procedures like vacuum, ventors, or many other, whatever complications may occur during a vaginal delivery or a cesarean section, that can show it as an informed consent to the patient?
See, anything you do in the labor room which can intimidate the patient when the patient is in labor may not be seen in a good light. See, कि labor ला जाते हैं. Labor has to be a very easy procedure for her and something that she should be happy about. There, if you are going to show her कि इथे PPH हो सकतं, इथे मरू शकते तू, all that cannot be. See, the information has to be given in a very positive way. Like tomorrow if a patient comes to you and patient is for say a hysterectomy and the patient comes and asks you, Namita doctor, what are the chances that I'll die on table during a hysterectomy? What answer will you give? Will you say that you've got 0.01% chance of dying on table? You cannot say that. So the way you put it is, beta, the chance of you dying on table during a hysterectomy is very, very rare. Have you said that it is zero? No. But have you said that in a
No.
positive way? Yes. So, in a positive way, you have to
Yes.
say it in a positive way. The information has been given that you can die on table, but in a very positive. If you go on the Foxy website and you read the uniform Foxy consent that I have devised for about 30 ops and gynec cases, you will realize that
Yes.
every point has been mentioned in that consent in a very positive way. Even things like amniotic fluid embolism, things like PPH, everything has been informed there, but in such a positive way that eventually it is like an informed consent. Everything has been informed like that. So don't fill your labor room with all that. In the labor room, whatever is needed for you, you can stick there. You may not some in some of the hospitals they will not want you to have some laminated book there where the resident doctor can immediately refer to that and write the notes.
Okay.
So,
Yeah.
so in some cases,
बोल
like
ना बेटा,
the
you were asking.
patient, they already Google things,
Yeah.
the complications during normal delivery, the episiotomy, the section, the pain during section, everything, the post anesthesia, backache. These all questions they carry in their mind, and entire ANC they are loaded with those stress. So, should we inform them like during ANC only, ki what are the things which can happen, which cannot?
Exactly. So that's exactly what I told you, na, that you during the ANC only you take this consent for vaginal delivery, na. You go on the Foxy website, I tell you, and see my consent for vaginal delivery. The consent for vaginal delivery, I mean, I have told her everything. So when she reads that and she discusses with you, then the other thing that I always tell you, it is not possible in your busy OPD to talk about every complication. It's just not possible.
It's
प्रत्येक पेशंटला तू सांगणार काय
no, 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 no.
एपिजॉटॉमिक गेप होऊ शकते
It's
and
totally
PPH होऊ
impossible.
शकतो. So that's the
No.
reason why what I say is collect all these patients together and have an antenatal class. An antenatal class is not
And
just Garbha
because the
Sanskar,
pregnancy also is a
not
happy
about
moment also, pregnancy.
exactly. So Garbha Sanskar is a window of opportunity for you to do all this counseling. I mean, apart from whatever you will be doing on Garbha Sanskar is a different matter, but you take it as a window of opportunity. Talk about what is the meaning of triple marker test. Can you, in your busy OPD, tell them that triple marker high risk does not mean 100% risk and low risk does not mean zero risk? Can you tell all that?
Zero
एवढा वेळ
risk.
असतो का
No,
आपल्याला?
No.
no, no,
Right. So you
no.
conduct a class. Garbha Samskar is only part of that class. The other part of the class is a window of opportunity for you to talk about everything. You talk about forceps, you talk about ventus, you talk about PPH, you talk about cesarean कसं होतं, कसा कट घेतो,
Yes, yes.
all that you talk there. and you give that information in that consent for vaginal delivery, that will stand in the court of law. Indeed, this doctor is taking efforts to educate the patient. Have your videos today. It is all it is age of technology. You can have your videos on antenatal class. So the moment the patient registers with you, send all those videos on the WhatsApp to her. So that can be proved in the court of law that I talked
Yes,
to
and
her about it.
you should do the visit also, labor room and OT also for a patient also before delivery.
Yeah, visit can be done. Definitely to make them feel comfortable,
Yes.
a visit can be done. Definitely. Whether you should allow the husband for delivery or not is a call that is very
Yes.
personal. I do not allow, but there are some gynecologists who allow the husbands to be there. I allow the husband to be there till she is fully dilated. Once she's fully dilated, I ask him to go out. And at the time of delivery, I don't allow anybody to be inside because they go to the extent of taking photographs and all that, which, see, there is a privacy between me and the patient, and that privacy I have to keep between me and the patient and not allow it even for the husband to breach.
Yes. Thank you, sir, for
Thank you
giving
so
us
much, sir.
important information about the medical legal aspects of maternal mortality.
See, actually, you will realize there is nothing like there is no need to have a legal knowledge for all this. This is all common sense. You have to just understand that you do your communication properly, you do your documentation properly in the court. But for the purpose of patient safety, you just have that in your mind and you will be saved in all the medical legal cases. Hey, it should be in your muscle memory that you have to write whatever has been done and you have to talk whatever you have written.
Okay.
ये दोनों है, document the communication and communicate the documentation. These two things you have to remember.
Very nice
Great message,
to
sir.
all yes.
Yeah.
Yes.
Right. So thank you so
you.
much.
Thank you, sir.
Until next time. Yeah.
Yes.
Thank you so much.
Thanks a lot.
Yes.
Okay.
Okay.
So we are ending here. Namita, thank you.
Yes,
thank you, Mr.
Thank you
Sir.
so much, ma'am, for the opportunity. Thank you, ma'am.
Always welcome, dear. It's a
Chalo.
nice,
Thank you, Namita.
nice presentation.
Thank you, sir. Thank you so much, sir.
Yes. Thank you, Priyanka. Okay.
Sir, our pleasure, sir, to see you.
Yes.
Both of you.
Okay. Chalo.
Okay,
Bye.
we'll
Good night.
meet you in the next webinar. Yeah.
Yeah.
Definitely.
Same here, ma'am. Thank you,
Okay.
ma'am. Bye, ma'am.
Thanks a lot.
Good night,
Thanks
sir.
for joining.
Bye.
Good night. Good night,
Yes.
everyone.
Good night. Good night.